Welcome and thank you for joining us for our monthly webinar series. My name is Leslie Kiesel and I work in marketing on the MCEDA team. Today we'll be discussing hypertension control and the Million Hearts Initiative presented by a few of our in-house experts. We also have a representative from the Michigan Department of Community Health to add into our discussion as well. Before we get started, I have a few housekeeping details to cover. We'll be keeping the phone lines on mute, but encourage questions. If you have a question, please enter it into the questions box, and we'll answer all questions at the end of the presentation. If we don't get to your question for some reason, we have your contact information and we'll answer you in writing at later time. We'll also be posting this presentation and a video of the presentation and the question and answer detail on mceda.org. A little bit of background for those of you who don't know MCEDA. We are the Michigan Center for Effective IT Adoption, a program that is led by the nonprofit Altarum Institute. We were chosen as Michigan's official regional extension center in 2009 by the Office of the National Coordinator. We're one of only 62 in the country. Our program is primarily funded through the Centers for Medicare and Medicaid Services and Michigan Department of Community Health to help accelerate the meaningful use of health information technology in Michigan. To date, we've helped over 4,000 providers with EHR adoption and utilization. In fact, 1/3 of all Michigan physicians that have been paid for meaningful use stage 1 are MCEDA clients. Our program offers highly subsidized health IT assistance for qualified physicians under grant funding. Paired with our fee-for-service offerings, we cover meaningful use support, security risk assessments, targeted process optimization, which is a hybrid of lean principles and best practice applications, attestation and audit prep assistance. Our presenters today are Laura Rapoli, Altarum's Public Health and Incentive Program Analyst, and Terry Wilson, Manager of the Heart Disease and Stroke Prevention Unit at the Michigan Department of Community Health. In the Million Hearts Initiative, what's being done in Michigan to date, how EHR technology can assist in achieving million hearts and individual practice goals, and how to join.
Okay, thank you, Leslie. So as we know, heart disease and stroke are leading causes of death in the United States. Heart disease is the first and stroke is the fourth. There are over 2 million heart attacks and strokes each year with 800,000 deaths. It is for every $6 spent on health care, $1 is for the treatment cost for heart attack and stroke. It is the greatest contributor to racial disparities in life expectancy. So how can we start to address these costly and prevalent conditions? We are proposing to focus on hypertension. It is one of the major risk factors for heart disease and stroke. Furthermore, it is one of the most important modifiable risk factors for a variety of other costly chronic conditions like CHD, stroke, and congestive heart failure. And as you know, what makes hypertension particularly troublesome as a risk factor is the fact that it is asymptomatic. While it is extremely easy to diagnose with just a few blood pressure readings, unless a patient is getting those readings, they're likely not to be identified as hypertensive because there are no other symptoms to alert the patient or providers to a potential problem. So why focus on hypertension? The cost. The estimated direct and indirect costs for hypertension in 2010 was $464 billion and is projected to rise to $274 billion in the next 25 years. However, because hypertension is a modifiable risk factor, there is opportunity to alter the course of that projection. It is also important to note that we are not only talking about a significant financial burden to the healthcare system, but a large number of patients as well. Current prevalence rates indicate that approximately 3 out of 10 adults in the U.S. have high blood pressure. While there is some variation by age group, the rates of hypertension are similar among men and women, increase as we age, and are the highest among African American adults. And those numbers are only expected to rise to an estimated 4 out of 10 adults by 2030. Within the hypertensive adult population, it is important to note several subgroups: the aware, treated, and controlled. Among hypertensive adults, only 82% are aware they have hypertension. And while 75% are using antihypertensive medications, only 53% have their condition controlled to target levels. Looking at the numbers a little differently, there is ample opportunity and a clear need to intervene with the adults who are unaware, untreated, or uncontrolled. As you can see, 1 out of 5 hypertensive adults still need to be clearly identified as hypertensive. 1 out of 4 potentially need to be put on medication or a treatment plan. Nearly 1 out of 2 hypertensive adults require intervention for treatment, adherence, and intensification to get their blood pressure controlled to target levels. And nearly 1 out of 10 need more intensive and comprehensive care to address resistant hypertension, where their blood pressure remains uncontrolled despite the use of 3 or more drugs, or is controlled only on at least 4 drugs. So where does that leave us? The CDC and CMS have teamed together to form the Million Hearts Initiative. And Bruce is now going to provide an overview of what the Million Hearts Initiative is.
Thanks, Laura. So Million Hearts is a national initiative with an ambitious goal to prevent 1 million heart attacks and strokes by 2017. This impact will be even greater over time. Million Hearts aims to prevent heart disease and stroke by improving access to effective care, improving the quality of care for the ABCs, and I'll discuss the ABCs more in a bit, but for now just know that this stands for appropriate aspirin therapy, blood pressure control, cholesterol management, and smoking cessation. Another focus of Million Hearts is focusing the clinical attention on the prevention of heart attack and stroke, activating the public to lead a heart-healthy lifestyle, and improving the prescription and adherence to appropriate medications for the ABCs. The Million Hearts Initiative focuses, coordinates, and enhances cardiovascular disease prevention activities across the public and private sectors in an unprecedented effort to prevent 1 million heart attacks and strokes by 2017, and demonstrates to the American people that improving the health system can save lives. Million Hearts scales up proven clinical and community strategies to prevent heart disease and stroke across the nation. It brings together existing efforts and new programs to improve health across communities and help Americans live longer, healthier, and more productive lives. The CDC and CMS are the co-leaders of Million Hearts within the U.S., or within the U.S. Department of Health and Human Services, working alongside other federal agencies, including the Administration for Community Living, National Institutes of Health, the Agency for Healthcare Research and Quality, Food and Drug Administration, the Health Resources and Services Administration, the Substance Abuse and Mental Health Services Administration, the offices of the National Coordinator, and the U.S. Department of Veterans Affairs. Key private sector partners include the American Heart Association and YMCA, among many others. Million Hearts is achieving its goal by emphasizing cardiovascular health across patients, providers, communities, and other stakeholders. Million Hearts brings together a number of programs, policies, and campaigns designed to make positive impact across the spectrum of prevention and care, promoting the ABCs of clinical prevention, as well as healthier lifestyles and communities. Some of the Million Hearts wide-ranging activities include instituting and monitoring aggregated or standardized quality measures for the ABCs, supporting team-based care that improves care coordination by utilizing nurses, nurse practitioners, physician assistants, pharmacists, dietitians, and community health workers to promote medication adherence and patient navigation to free and low-cost drug programs. Educational campaigns to increase awareness about heart disease prevention and empower patients to take control of their heart health, and the use of health information technology and quality improvement initiatives to standardize and improve the delivery of care for high blood pressure and high cholesterol. Community and national efforts to promote smoke-free air policies and reduce sodium in the food supply, and empowering healthcare providers and systems to improve cardiovascular care through EHRs, registries, and point-of-care improvement strategies, which I'll expand on a little more later in this presentation. So a main component of Million Hearts is this focus on the ABCs, or ABCS. Here we look at the baseline on these metrics and the goals of the initiative. So a primary program goal is to get people at high risk for heart attacks and strokes to take a baby aspirin every day. Fewer than half do right now, or did at the beginning of the program. The government wants to get that up to 65%. The program also looks to raise blood pressure control from less than half the people with hypertension now to 65% by 2017. Cholesterol control will need to more than double to reach this new target of 65%. Right now, we're at a meager 33. At the start of the program, less than a quarter of people who smoke were getting evidence-based help to quit. The program looks to push this up to 65% as well. Studies have shown that getting doctors to urge patients to quit doubles the likelihood of a successful quit attempt. Those are remarkable and powerful results. The program also pushes for a 20% reduction in Americans' daily sodium intake. This is being achieved by patient education and commitment, but also through the efforts by the FDA to work with the food industry to reduce the amount of salt in food before it even reaches our plates. And similarly, the government is working to eliminate artificial trans fat in purchased foods, chemicals that raise levels of bad cholesterol and lower good cholesterol. So when Million Hearts is a success come 2017, what this means for us is 4 million fewer people will smoke in the U.S., and 10 million more people with high blood pressure will have it under control. Those are amazing numbers. And with that, I'd like to turn things over to Terry Wilson from the Michigan Department of Community Health, who joins us to discuss many of the great hypertension initiatives currently underway around the state. Terry, are you there? One moment, please. We might be having some technical difficulties. We had Terry on the line earlier. She's speaking to us from Lansing, of course. Hopefully speaking to us from Lansing. Terry, when you, if you're able to speak, just let us know through the presentation. I'm going to buzz ahead to my section. We'll circle back to this part of what's happening in Michigan. All right, so we fast forward a little bit, and I apologize for the technical problems. We'll talk a little bit about how technology can help you to identify, monitor, and engage patients. Get ahead to my slides here. So there are many ways that providers can leverage their EHRs and other health information technology to drive their hypertension control efforts. The following slides will examine specific ways providers can use technology to identify, monitor, and engage their hypertension patients. And we'll also discuss how the EHR incentive program, otherwise known as Meaningful Use, plays a role in this initiative. So one of the key ways, one of the simplest ways to help identify those patients is making sure that you're keeping and updating your problem list in your EHRs. Pretty straightforward. You just got to make sure that you're getting that information in there. It also is a core requirement under Meaningful Use in Stage 1. It's not in Stage 2, but regardless, I mean, it's an important task that we need to be doing on all of our patients. Second, we can take blood pressure reading for every patient and capture it in the EHR as structured data. Can't stress enough how important it is that this data is actually being entered into the EHRs correctly in the right places to make it structured data. Structured data just means that you're entering it into, whether it's a radio button or in the case of BP, you're actually entering that number into a specific field. If you are not doing that and you're just entering this data into a dictated note or just typing it into a free text field into your EHR, you lose the ability to be able to report on that data and run reports and really make the most of that information. Thirdly, an additional way to identify is through recording the smoking status. It is a core requirement under both stages 1 and 2 of meaningful use. So again, just got to make sure that you're getting that information into the EHR so that you can identify your patients. Additionally, 2 additional ways to identify. We can generate lists of at-risk patients. So this was a menu requirement under stage 1 of meaningful use. It's a core requirement of stage 2. It's literally just picking a disease state. In this case, it would be hypertension, and running a list out of your EHR that can list all of your active patients that are currently hypertensive. Back in the old days, back in the paper world, you can imagine or you can remember how difficult that was. It was more of a needle in a haystack to try and identify those people. But now with our EHRs and the ability to very quickly and easily generate reports, it makes it so much easier to find all those needles in the haystack. Lastly, under Identify, there's the data sharing that's happening, both when you are sending patients somewhere else as well as receiving patients, whether it's from the hospital or from another provider. We're sharing that information out of our EHRs now. So when you are sending a patient out, you're sending a summary along with them, or you're forwarding a summary that can help that incoming that next provider to identify their hypertension patients. Same thing when you are receiving patients now, whether it's discharged from the hospital or from another provider, you should be receiving information that can really help you identify hypertensive patients before they even walk in the door. Moving on to monitor. One of the foremost ways to help monitor your hypertensive patients is through tracking the clinical quality measures. This is a meaningful use requirement in stages 1 and 2. Here we have a list of the CQMs that are tied to the Million Hearts initiative. And if you can, and your EHR offers them as options, you should choose from these 10 CQMs to help support the Million Hearts initiative and the hypertension control among your patients. And as you can see, different programs like Meaningful Use, PQRS, and ACO all share these common CQMs. Clinical Decision Support, or CDS, provides clinicians, staff, patients, or other individuals with knowledge and person-specific information intelligently filtered or presented at appropriate times to enhance health and healthcare. CDS encompasses a variety of tools to enhance decision-making in the clinical workflow. These tools include computerized alerts and reminders to care providers and patients, clinical guidelines, condition-specific order sets, focused patient data reports and summaries, documentation templates, diagnostic support, and contextually relevant reference information, among other tools. Countless CDS rules can be used to help you monitor your hypertension patients. Offices can also leverage their technology to remind patients of upcoming appointments or prompt them to make an appointment for preventative or follow-up care. They can also make use of existing hypertension registries available within the state and even nationally for tracking these patients and providing key data to aid in population management. Moving on to Engage, one of the best tools we have now in 2014 for engaging our patients is through these patient portals. It is a core requirement under meaningful use. Doesn't matter what stage you're in, stage 1 or stage 2. If you're going to demonstrate meaningful use this year, you will have a patient portal up, live, and active. And through that patient portal, providers can push out relevant info to patients, but patients can also use that same technology to email or correspond with providers, which is actually an additional core requirement under stage 2 if you're in the meaningful use program. Patient education on health info and resources. If you're using a certified EHR product, doesn't matter if it was certified under 2011 or under the new 2014 certification, your EHR has built-in education resources. As you are charting on these patients, as you click off that they're a smoker, as you click that they're hypertensive, your EHR is in the background giving you a subset of patient education that's built right into the system. And you just click on that information, print it out, and give it to the patient. It's a tremendous resource for giving patients the education that they need based on the visit that they're right there with the information that they're providing to you right then and there. Additionally, this steps out of the EHRs a little bit, but you can also connect patients to home monitoring and journaling, which can be transmitted and entered electronically. There's this program, Heart 360, which was it's a pharmacist-led home blood pressure monitoring program that participants upload their home blood pressure measurements 3 to 4 times a week to the American Heart Association's 360 website. The clinical pharmacy specialists monitor the patient's blood pressure readings and adjust medication therapy as needed. This program has led to improved blood pressure control, increased reduction in blood pressure, and improved patient satisfaction with care for patients with uncontrolled hypertension. So just another way that we can use technology to help engage those patients and control hypertension. And then finally, just the process changes, where we're running those hypertension-related CQMs quarterly, and then making changes as needed based on the results. So overall, I bring up this slide just to kind of talk about the EHRs or technology in general and the vast benefits available to us here. So under quality and convenience, with EHRs, patients' health information is available in one place where and when it's needed. Providers with busy practices and patients with busy lives appreciate convenience in their healthcare transactions, and Health IT can help. For example, with e-prescribing, patients can have their prescriptions ordered and ready even before they leave the provider's office. And providers may be able to access patient files or submit prescriptions remotely from home or even while on vacation. Additional benefit with the increased patient participation, information technology is at the heart of modern life. It touches different people in different ways. And some are comfortable with new technologies, and others may be intimidated, at least at first. EHRs, PHRs, and other health IT developments tend to make many patients more active participants in their own health care. As providers adopt these new technologies, it's important to keep the patient's perspective in mind. Improving the accuracy and diagnosis and health outcomes. When health care providers have access to complete and accurate information, patients receive better medical care. EHRs can improve the ability to diagnose diseases and reduce or even prevent medical errors, improving patient outcomes. Improving care coordination. EHR systems decrease the fragmentation of care by improving care coordination. EHRs have the potential to integrate and organize patient health information and facilitate its instant distribution among all authorized providers involved in a patient's care. For example, EHR alerts can be used to notify providers when a patient has been in the hospital, allowing them to proactively follow up with the patient. With EHRs, every provider can have the same accurate and up-to-date information about a patient. This is especially important with patients who are seeing multiple specialists, making transitions between care settings, or receiving treatment in emergency settings. Better availability of patient information can reduce medical errors and unnecessary tests. And better availability of information can also reduce the chance that one specialist will not know about an unrelated but relevant condition being managed by another specialist. Better care coordination can lead to better quality of care and improved patient outcomes. And then finally, under practice efficiencies and cost savings, many healthcare providers have found that EHRs help improve medical practice management by increasing practice efficiencies and cost savings. EHR-enabled medical practices report improved medical practice management through integrated scheduling systems that link appointments directly to progress notes, automate coding, and manage claims. Time savings with easier centralized chart management, condition-specific queries, and other shortcuts. Enhanced communication with other clinicians, labs, and health plans through easy access to patient information from anywhere. Tracking electronic messages to staff, other clinicians, hospitals, labs, etc. Automated formulary checks by health plans, order and receipt of lab tests and diagnostic images, and links to public health systems such as registries and communicable disease databases. In short, providers and provider offices should be leveraging the many aspects of health information technology to manage their hypertension patients. Failing to capitalize on the many ways health IT can be used means not maximizing your return on investment. Providers owe it to their patients and themselves to ensure they're making the most of the available technology. All right, with that, I think we have Terry on the line. Terry, are you with us now?
Can you hear me?
Yes, we can.
Yes.
Okay, great. I was unmuted, so I'm not sure what happened.
Yeah, me
On
either.
my
but,
end, I'm
we're-
not sure, but I'm glad. I switched over. Actually, I had my headset on, and I switched over just to my phone. So I don't know if, but I could hear you. So I don't know if it was something with my microphone on my headset that that maybe just decided to stop working.
Well,
Okay.
we're
Well,
glad to have
I'm
you.
sorry about that, and I know it seems like we're kind of going backwards, but actually, maybe not. I mean, because you talked about your initiatives. I'd like to talk a little bit about what's happening in Michigan. And first, though, I'd like to give a little bit of a background of the burden of hypertension in Michigan. Michigan rates 12th out of all the 50 states for rates of hypertension, so it's about 34.2% of adults have reported that they were diagnosed or told by a healthcare provider that they had hypertension. And that was from 2011 data from the Behavioral Risk Factor Survey, the Michigan Behavioral Risk Factor Survey. If it continues at this rate that we're going, it's projected to rise to about 2.6 million cases by 2030. And what we know is that about a little bit over 75% of adults who have been told that they have hypertension were taking medication in 2011. So we still have a long way to go because that's not, it's not close to 100% that are reporting of those who have hypertension that they're doing something to have it under control. So that the Michigan Healthy People 2020 target is to reduce the prevalence of hypertension among adults in Michigan to 26.9%. And with National Million Hearts, it's increased rates of hypertension control to 65%. It's kind of difficult to determine with hypertension control. There's many components to it. At this point, we're only really able to determine whether a certain, the certain reading of like less than 140/90 is being controlled, whether it's through physical activity or diet or the medication adherence. So with the Healthy People 2020 target and the National Million Hearts 2017 target, we still have a lot more work that needs to be done. Our initiatives in Michigan, and again, for hypertension, this is a blood pressure less than or equal to 140/90 in the majority of adults. We have had some recent guidelines, and actually they're going to be guidelines that are going to be published for next year. There's still some debate about it, about looking at older populations, for instance, 65 and older, having blood pressure about 150/90 being considered high blood pressure. But at this time, it's still the blood pressure is considered high, whether it's, I'm sorry, I might have said less than, greater than or equal to 140/90 in adults over the age of 20. So I apologize, I said less than before, and I meant it's blood pressure greater than or equal to. So what are we doing here in Michigan? Currently, we are funded by CDC to work on domains 3 and 4. CDC has 4 domains that is the priority for them. Domain 1, when it comes to chronic disease, health promotion, prevention, and chronic disease. Domain 1 is epidemiology and surveillance. Domain 2 is environmental approaches that promote health. Domain 3 is health systems interventions. And Domain 4 is community clinical linkages. So at the Michigan Department of Community Health, we are focused on addressing hypertension with Domains 3 and 4. And hypertension is really the priority for our program, increasing hypertension control among Michigan residents. That is a program priority for heart disease and stroke prevention at the Michigan Department of Community Health. So with Domain 3, we are focused on increasing implementation of quality improvement in health systems. This includes increasing EHR adoption and reporting of hypertension and diabetes control among primary care practices. Also, with our work that we're doing for CDC, it's part of a collaborative grant, and so many of our activities that we focus on for hypertension are also integrated activities where we're working on increasing the control of diabetes as well, because it definitely makes sense to address both of those together, since the majority of patients diagnosed with diabetes also have hypertension. So in addition to increasing EHR adoption, it's increasing utilization of chronic disease registry functions and data to improve the quality of care among patients diagnosed with hypertension as well as other chronic conditions. Increasing engagement of non-physician team members, such as community health workers in hypertension management, specifically increasing the partnership between primary care practices and CHWs. Providing resources to health clinics and primary care practices that are currently not implementing the patient-centered medical home or chronic care models to improve hypertension and diabetes management. In addition, we are working on increasing engagement of community health workers to promote the linkages between health systems. Again, there's that community clinical linkages between health systems and community resources for adults with high blood pressure. And I just wanted to put some of the partners that we're working with, and I am excited to say that we're also about to embark on a partnership with MCEDA as well. But we are currently working with the Michigan Pathways to Better Health Self-Management Education Pathway, where we've worked with MPBH. They're also funded by CMS but guided by CDC. They have education pathways that are focused on the social determinants of health, and for clients to be eligible to receive services through this, they need to be diagnosed with 2 or more chronic conditions and be receiving Medicaid or Medicare or both. And what we did was we helped them develop a module specifically on hypertension. So a community health worker can educate a client on hypertension if the client has reported that they have been told by a healthcare provider, and they're able to determine that through an assessment that they're given. There soon will also be a diabetes module that will be a part of this, and this is kind of still in a pilot phase. Also, the Michigan Community Health Worker Alliance CHW assessment, and this is an assessment that we are doing with the University of Michigan, as this is where the MISHWA is their acronym is housed, and how they're funded. So this will be an assessment that we're helping them. We help them to kind of revise the survey, and this is the second time that they've implemented the survey. And really the purpose is to determine where CHWs are employed, what kind of systems they're employed with or institutions in the state of Michigan, where they're located, and how they're utilized. And also our work with them is to also provide education, educate about and promote the use of community health workers in the patient-centered medical home and chronic care models. And this involves primary care practices and to assist and improve management of hypertension and diabetes. What I also wanted to say about the Community Health Worker Alliance assessment is that by determining, if we can determine where CHWs are, where they are located and working in the state of Michigan, it helps us to determine where they are not, to target where they may be needed. So next slide, please. In addition, the Heart Disease and Stroke Prevention Unit at MDCH provides resources. As a state health department, we are here to always provide technical assistance and provide resources as needed, and also to our partners as they need them. And we also have, so one of our resources that we have online, it's on our section website is High Blood Pressure University, and this includes high blood pressure resources for professionals, patients, and community groups. And it's divided up and categorized just in that manner. And also it also provides clinical guidelines whenever guidelines are updated. As I mentioned, soon we'll have an update next year from the American Heart Association. And also training. We also provide training and reference materials. We have different office tools and educational resources specifically focused on hypertension control. For instance, we have a brochure on the DASH eating plan to reduce sodium intake. We have a bookmark with some bullets on hypertension control that primary care providers or care managers or primary care practices and other types of healthcare providers can provide to clients, in addition to other sodium brochures. But on the website, we have multiple resources that providers and patients and community organizations can go through. Some of the educational resources also can be, they're in hard copy, and they can be ordered through us as well. But I wanted to also include the link to the website that can directly get you there for the resources, which is michigan.gov/CVH. So something that we have come up that is definitely, I mean, overall, as you've seen some of the initiatives, the objectives, the strategies that we're working on definitely align with Million Hearts, the Million Hearts initiative and recommendation, as Bruce explained. But we are also holding a workshop that's coming up. It's a Million Hearts stakeholder workshop, and the purpose will be to bring together organizations and partners from around the state, so it's existing partners as well as hopefully it'll provide us with the opportunity of developing new partners and for partners to network amongst each other that play an important role in addressing hypertension awareness and control. And we received this, we received a technical assistance opportunity from the National Association of Chronic Disease Directors, and they are the ones facilitating this workshop for us. And the key objectives include understanding the Million Hearts Initiative and how organizational and state activities can be aligned to support the goal of Million Hearts. We have Dr. Robert Lando that's coming from the Department of Health and Human Services. As Bruce mentioned before, Million Hearts is something that is under CMS, which is under the Department of Health and Human Services. So this Health and Human Services representative will be doing the presentation on Million Hearts. And also we're going to be having our medical director that will present information on how the Affordable Care Act is changing the healthcare landscape with specific examples, with hypertension as a specific example. Also the benefits of using electronic health records for reporting and tracking patient blood pressure to improve hypertension control and including the patient in that self-management of control of hypertension, and Bruce mentioned some of that, how that could be done with EHRs and meaningful use. And also the role of community health workers and other healthcare extenders in supporting care managers in primary care settings. So you can see especially the last two bullets, they're focused on what we're already doing in Michigan, where we want to expand our efforts, specifically with EHR adoption, meaningful use, and that team-based care approach that includes the role of community health workers, because they can be a very valuable asset and role to a team in addressing hypertension as well as other chronic conditions.
All right, thank you,
So
Terry.
with that, I'll turn it back to Bruce and Laura for any concluding comments. But thank you again, and I apologize that we had some technical difficulties and that my presentation was delayed.
No problem at all. Terry, before you go, or I know you're not actually leaving, but before you go silent on us, a couple of questions came in while you were talking, and they're addressed to you. So I'm going to fire these ones at you now. And as Leslie had said, anyone else, if you have any additional questions, we're going to keep the lines muted, but please use the question function in the GoToWebinar interface to submit your question. So a couple questions. First one, how do you become a Community Health Worker Alliance person? How would somebody go about that, Terry?
To become a member, I would say we could definitely provide the contact information for the Alliance, and they would be able to. We have a contact. Her name is Katie Mitchell from MISHWA, and I would think to contact them, and they certainly could give you that information. So that's something that I can provide. I don't know if, Bruce, would I provide that to you to follow up with the participant?
Yeah, if you want to send that to me. To answer another question that came in, we will be sending out a copy of the presentation to all the attendees, and I'll hold off to send that out until I get this information from Terry, and we'll make sure that that information is there as well.
Okay, and I know in the Cardiac Alliance, I'm sorry, Cardiac Alliance, I'm thinking of something else. The Community Health Worker Alliance also has a website where there is contact information if you wanted to do that, but we certainly could follow up, and this way it's directly provided to the participant.
Great, thank you. Another question that I think comes to you, Terry. How can we access the Pathways program or make referrals?
Well, currently with the pathways, and I didn't include, I know we have some time issues, but with pathways, that is a pilot that currently is occurring in Ingham County, Muskegon, and Saginaw that is funded by CMS. And the Michigan Public Health Institute is also involved in that. And so I'm thinking that we could definitely put the person in touch with Tom Curtis, who is the contact for that project. But unless you're in unless you're located, I don't know if this person is located in any one of those counties, but I would think that Tom would be a great person to follow up with to find a little bit more about the project, because certainly I didn't provide all that background, but I just can say that it is something that they can look to, maybe even to replicate in their own community or county, but definitely to talk with Tom, and he can give a background and talk a little bit more about it. What we know is that there is hope that the Pathways project, as part of it's also called a hub, with the community hubs that are the sources of referral and information that the community health workers also connect with. And in fact, the community health worker is usually referred to a client through the hub because they receive the information from the primary care practice. There is hope to expand that. It's just a matter of funding, and currently we're looking at opportunities to be able to expand the Pathways project to other counties. But I would still say that Tom would be a good person to start with, just to talk to and get some more information about that. And I can provide that, again, Bruce, with you all. I can provide Tom's information, contact information, if that's helpful.
That would be. Thank you, Terry. One more question came in. Is there funding for the community health workers through CMS, et cetera?
Well, currently, as we know, for the Pathways project, for the community hub and Pathways project, I'm not sure what other funding opportunities there may be, if I'm understanding the question right. But from what I know, this is one of the only projects I know that there's funding from CMS. I know, for instance, that Spectrum Health, their healthcare system, also employs community health workers. I'm not quite sure how they're funded, but I'm not quite sure. Maybe that's a good. That could be good to follow up with CMS or have a contact there and figure out. Maybe there could be grant opportunities or other ways there could be funding. What we know too is that there's just certain health systems and institutions and organizations that have invested the funding, some of their own funding for CHWs, especially in determining where there's a need, especially with that community clinical linkage and that relationship between the primary care practice and the community health worker. So I'm sorry if I'm not really helping with that question.
Thank you, Terry. I appreciate it. All right. Buzz down. I think we had one final slide here. And this was on how to join the pledge. So what can our participants on the line do? First and foremost, you can go to millionhearts.hhs.gov and join the Million Hearts campaign. It's as easy as that. MCEDA is also here to help providers leverage their health IT to track and measure success on 2 of the Million Hearts measures. But really, as you heard me talk about, MCEDA is here to help you leverage your health IT, period. And there are a lot of different ways that you can leverage that health IT, as you heard, to track and monitor and improve your hypertension patients. And then we're also here to work with you to set up automatic reporting, determine an appropriate course of action for your patients, can help you rerun those same reports and look over them and determine if hypertension control, if you're reaching the goals that you set for yourself, and then to help improve that overall quality for your patients. And doing that can help you change direction, can help you change focus. If you're working on an initiative, you're running those reports, and you're not seeing the results that you're looking for, MCEDA is here to help you with that as well. Just overall, we're here to help you leverage the health IT, whether it's for meaningful use, for helping you manage your hypertensive patients, or anything health IT related. With that, we want to open it up to any additional questions, either for myself or for Laura or for Terry on the line. We've had a couple of other ones come in as well. What's the easiest way of tracking hypertensive patients in my EHR? So I think for that, when one of the first point, I think the first bullet point on that slide for identifying was running those lists of patients. So your EHR has capability. As long as you are recording that information as structured data, you know, there is the unfortunate garbage in, garbage out. So if you're not using your EHR in the right way and flagging those patients in the right way, you're not going to be able to run those reports. But certainly if you are documenting the way that you're supposed to be, the way that your EHR is designed to, the easiest way of tracking your hypertensive patients is simply to run a report. You know, have your EHR give you a list of all your hypertensive patients, but then you can also add additional fields like the date of last visit or what their last BP was, and just build a report that gives you a wealth of information about tracking your hypertensive patients. Another question: if I want to join Million Hearts and selected hypertension CQMs for meaningful use, would that qualify for both meaningful use and PQRS? So yes, I can back up to the slide that has all of the clinical quality measures that are specifically related to Million Hearts. And as you can see, Million Hearts, meaningful use, PQRS, all 10 of these all fall within those programs as well. And the ACO picks up most of them, and even the Medicare Advantage program has a couple of them as well. So certainly, you know, you don't have to select CQMs in a tunnel. You know, you make sure that you are making the most out of your selection and are selecting CQMs that qualify for the various programs. So you get kind of a two birds with one stone thing going on. Last question we have so far is, where can we get patient education materials for our practice? Well, one way is out of your EHR, as I mentioned. There's a wealth of patient education that's built right into your EHR, as long as you're on one of the certified products, whether that was certified under the 2011 or the 2014 versions. There's a whole database of patient education. Additionally, if you go to the Million Hearts website, which again is millionhearts.hhs.gov, there is a tremendous amount of information and toolkits and flyers and just an amazing amount of information for you and your patients to use. And also, you know, I think Terry would say, and we can go to the state of Michigan's website as well. She mentioned the Blood Pressure University has a lot of patient education, a lot of education materials there as well. So there's certainly no shortage of places where you can get patient education materials. That looks like it for the questions at this time. So with that, I'll turn it back over to Leslie.
Sure. We appreciate everybody attending today, and hopefully you got a lot of good information from this webinar. Our next, just as a reminder, we typically do our webinars every month on the first Wednesday. This month was an exception to the rule for spring break reasons. And the next one is decrypting the security risk assessment requirement for meaningful use. So that should be helpful for those of you out there who are still scratching your head on exactly what's required and how far you have to go in terms of documentation. So we'll be having one of our in-house experts talking on that. It's May 7th at noon, and we're all wrapped up. We hope you guys have a good lunch and appreciate your attendance. Thank you.
Thank you, everybody.